the strength and the capacity of partnerships between community-based organizations, including area agencies on aging, but the disability organizations as well, so those community-focused organizations, to partner with healthcare systems and help these two systems become integrated and talk to each other more effectively. Ultimately, again, the aim is to expand access to those home and community-based services, social determinants of health in homes and communities for older adults. So until 2018, there were limited opportunities within both traditional Medicare and Medicare Advantage because long-term services and supports were not covered under Medicare, specifically home and community-based or social determinants of health. They were not considered part of the healthcare system. However, given the evolving landscape that you've heard about today, and per Allison's introduction, Congresswoman's introduction, what I'd like to focus on is how I hope that area agencies on aging and other community-based organizations can help Medicare Advantage achieve their goals of keeping people healthier at lower costs and more independent in their homes and communities where they want to be.
Great. Okay, good. We have a whole future out there to figure out together, which I think you'll keep hearing. And Gary Puckrein, will share some words with us from your perspective about the things you've heard today and where we're going with Medicare Advantage.
Yeah, good afternoon, everyone. So let me quickly introduce the National Minority Quality Forum. We are an education and research organization based here in Washington, D.C. Our focus has been on collecting health data. We started collecting data when back in 1998, when we were supposed to be eliminating health disparities through Healthy People 2010, if you remember. Over those years, we've built a database now of over 5 billion patient records. We collect data on 100 million lives a year across 72,000 conditions. What we do with that data is we partner with patient advocacy groups. As we move into the digital age, one of the things that we want to make sure of is that patient advocacy is moving along. And so if you look at organizations like Us Against Alzheimer's, the Lupus Alliance, N4A, all of those are being driven by data that we've collected. And we've built an online tool, so we've aggregated the data by congressional district, so we can actually go in and see what's happening to your constituents. We also do it at the state legislative level, and so we work a lot with state legislators on Medicaid data. The important takeaway for this conversation that I think is really important for you to bear in mind, because I think of you as the trustees of the Medicare program. The American public has put their trust in you for the revenues that come out of their salaries. I mean, that's essentially how the Medicaid program is funded. And here's an important thing for you to know, and it's kind of underlying the conversation today. The median household income of a Medicare beneficiary is $26,000 a year. So what that means is half of the Medicare population has less than $26,000 a year in household income. When you start to look in the fee-for-service program, and you come up with those copays. So if you go to the doctor, it's 20%. If you go to the hospital, it's 20%. If you go to the emergency room, it's 20%. If you have durable medical equipment, it's 20%. It's unaffordable, right? It's just literally quite unaffordable for populations. And that's what people are talking to you about, is that they just do not have the capacity to do that. On average, when you look at it, those out-of-pockets can get to be somewhere around a fifth of their household income a year. That's why people are moving into Medicare Advantage. And when you look at minority populations specifically, their household incomes are well below that 26%. And that's why so many minority populations are moving into Medicare Advantage. So what we look at it, what we're interested in, and it was implicit in some of the conversations today, as we move deeper into the 21st century, we can actually control health outcomes. What I would say to you is that hospitalization is highly predictive. I can look at a zip code and tell you how many people are going to have a cardiovascular event in a zip code. I can tell you how many people are going to go on dialysis, et cetera, et cetera. We're not using that data, that information really to drive our healthcare system. And that's what we're about. We're very much interested in that. So we support on both sides, Medicare Advantage and Medicare fee-for-service. Our heart is with Medicare Advantage, not just because of the copay issue, but because we also need to be able to provide services to Medicare beneficiaries. Services include dealing with those social determinants of health. But if you think about it, in the Medicare fee-for-service program, if you have a chronic disease, you go to a doctor, there's no follow-up. There's no one there to sort of help you manage, do care coordination, and all those sorts of things. And that's what's different about the Medicare Advantage program, is that there's a team out there that is working with you. So we're excited. We, as I said, we do a lot of work with patient advocacy groups. We try to get the numbers into their hands, and certainly from time to time suggest to them better ways that we might to use those funds that the American public has put in trust to you. And certainly we think the Medicare Advantage program is a great place where those dollars are getting used.
That's great. No, thank you. Lucy?
Okay. Hello, everybody, and thank you for being with us this afternoon. I'm Lucy Theilheimer. I'm the Chief Strategy and Impact Officer for Meals on Wheels America. Meals on Wheels America is the national voice, the representative, and support for the network of some 5,000 local senior nutrition programs. And I think one of the things that's unique about that is these are the folks who are on the ground every day going into the homes of the population that we are talking about today. You have a fact sheet in your packet, and for decades, this network has been about serving those who are most frail, most vulnerable, the population that is served by local Meals on Wheels programs is disproportionately older, over 75, disproportionately low income, disproportionately diverse, disproportionately women, disproportionately multiple chronic conditions, multiple medications, functional limitations in activities of daily living. So every day, this network of local providers is coming into contact with this very population. And I think that's what they bring to the table, is this opportunity to really partner with healthcare. So at Meals on Wheels America, we're about advocacy, we're about research, we're about seeking to partner and integrate with healthcare, we're about education and training, everything that it's going to take to enable this network of local programs to be a key central focal point, if you will, for partnering with healthcare to meet the needs of the frail and vulnerable population. We've been working with a multitude of healthcare organizations. We actually do have several contracts and pilot projects right now with Medicare Advantage plans. We're learning a great deal through that process. We are looking to see those expand as well as other kinds of healthcare partnerships. And I'll be happy to share some of that. I know that Congresswoman has some questions she's going to put to us, so I definitely have some learnings and insights about where we are in our work with Medicare Advantage.
Oh, that's great. And I do want, if you have questions, I'll just kick one off just to follow up on that. Because there are a lot of high expectations that have been put out there with the addition of the possibility of these supplemental benefits. You saw the list that Ann put up. They're not universal. What's interesting, and I think Ann pointed this out, is that plans can choose which ones. Like most plans offer some dental, vision, hearing, these wellness programs, these fitness programs, which turn out to have a huge impact on your health care. But these additional benefits there's no extra money. So that money comes from within the amount of payment that Medicare Advantage gets. So I guess the question then is, what do we see? These are high expectations. What do you see in terms of the kinds of choices that plans are making? How much are they reaching out to you? Are they interested more in care in the home, in meals, in some of that transportation we heard about, or addressing even, and I think Gary sort of implied this also, communities and how healthy the community is or not. That's actually asking them to take on a lot, but there's some who are doing it. So Lucy, we'll start this way, and you can each sort of talk about how you see this playing out.
talking points there. But
I did ask a question on
You
the end.
did ask the question. Just before we even jump into this, I just want to acknowledge that the problem of senior hunger and isolation and the needs of complex populations is not going to be solved with one solution. Medicare Advantage is one of many solutions. We are still going to be relying on the funding that comes through the Older Americans Act and other kinds of initiatives to support this population. That said, this is a very exciting step for this whole community that is interested in trying to serve this population. And we, like others, are very excited to be part of it. And we are expecting the Medicare Advantage plans will increasingly reach out to us. Interestingly, over the last, I would say, year to 18 months, they've been doing this even before the expanded supplemental benefits came out. So we had plans reach out to us to talk about how could Meals on Wheels programs help them serve their high-need, high-risk populations, their special needs populations. And what's interesting is they have different priorities, right? So we've got one major plan that's interested in food insecurity and social isolation. We have another plan that's interested in tapping into a protocol that we've developed that's daily monitoring of changes in conditions and catching problems before they become significant and somebody winds up in the emergency room. So there is we've had people inquire about grocery assistance programs and all different kinds of services. It's a good match for Meals on Wheels. We talk about Meals on Wheels as the more than a meal service model. That means they're providing nutrition, but they're doing in-home assessments. They're doing safety checks and removing fall hazards. They're providing oftentimes the only social contact that a senior may have in a given day. They're connecting them to other community services that may be helpful to help them stay in their own homes. So they are talking to us about that whole breadth, but as Congresswoman says, there is no additional funding. There is a bit of a myth that because Meals on Wheels programs rely on volunteers, that somehow it's all free. I'm here to tell you that's not true. What's becoming interesting is what we're seeing is these plans didn't leap, at least to our knowledge yet, it'll be interesting to see, have not leapt into taking advantage of some of the new flexibility. We're hoping to see much more action for the 2021 bid cycle. Because A, to Congresswoman's point, they're trying to figure out how are they going to offer this, what services are they going to offer given that they don't have additional funding. And I think the other thing is important is you see more in Medicare Advantage of growth around innovation, population health on one side of the company. On the other side of the company, you got the actuary guys who want to know what's the change going to be for their per member per month cost, right? These things haven't quite come together yet. And these services for chronically ill, complex needs are not inexpensive. And so from our perspective, for example, there's a really important place for food providers who ship meals for 2 weeks to somebody after they've been in the hospital and they just need a little bit of help. That's not who we're talking about here. We're talking about people who have complex needs over time. Changing the mindset from an economic standpoint is going to be important. So I'm going to stop there. We're very excited and we're continuing to work with those plans.
Try this. And actually, you may want to talk too about how prepared or not some of your members are to take on this new world of what I have to negotiate with a plan. I mean, what's this about? I'm used to getting my grant funding and hope for the best.
Yeah, I think that is a critical point. This is an exciting step. It is an exciting step, but it is only a step. I think the potential is huge in the move to expand access to these supplemental services, but success is incumbent upon area agencies and other community-based organizations, as well as Medicare Advantage plans, understanding and recognizing the value that's inherent in these services and investing in that value. And that key part, the key part of that sentence is investing in. These services are not free. Just because they're community-based, just because they're social, they are not free, and simple referrals to or building awareness of the services is not going to be sufficient. So ultimately, I think the devil will be in the details of working out contracts between Medicare Advantage plans and the area agency network or other community-based organizations. And I think in terms of the preparation, a change is hard, certainly. And this will be a learning curve for both Medicare Advantage as well as community-based organizations. But there's lots of work that's already been done out there to help lay that baseline for developing these contracting opportunities. And the Aging Network, while we still have a long way to go, has done the hard work of trying to break out of that mindset of getting grant funding through Older Americans Act or other sources to, okay, now we actually have to prove our value. We need to show what the return on investment is. So again, there's work to be done still in that way, but the progress that's been made in other areas is certainly exciting. But I think ultimately I just want to point out that because Medicare Advantage serves vastly more people than are served through the Older Americans Act or even through Medicaid home and community-based services, that this is potentially a paradigm shift if we can give it the time and the investment and the work that it requires to fully incorporate and integrate these services.
Really interesting. Gary, do you want to talk a little bit about the role of community? And you talked about zip codes, so and how much responsibility do you think Medicare or Medicare Advantage in particular can take for some of that, and what's happening out there in the real world?
Sure. So at least inside our organization, one that we think about is that when you think about it, healthcare is actually a deep collaboration down at the community level. It's not just the interaction between the physician and the patient. It's also the social services that support it. It's you, the policymakers, that set up the access program. When we think about it and look at the data, what we're saying to ourselves is, so how do we optimize all that? How do we make sure that we're able to provide the best quality care for really diverse communities, which is also challenging in that we don't have monolithic communities out there. They're highly diverse, from language spoken to, when I think about Meals on Wheels, I say to myself, Jesus, you're going to deliver meals to Koreans and Hispanics and African Americans. And these are really complex things that we're taking on. But our sense is we have really the capacity to do it. And it really starts on your side of the ledger, because you have to create the opportunity through good, strong policy. And when we think about it, what we say to you is precision policy. You got to use the numbers, right? This is all data-driven now. You can't make it up because that community collaboration breaks down when the data isn't right, when the policies aren't well aligned. And so from our side of it, what we urge you to do is really use the data, really use the analytic capabilities that we now have. And I think we can really get measurable, high-quality outcomes for patients if we do that.
Right. And do you want to add something? It was
just
great.
bravo.
It is interesting. Anne pointed out a really important point, is that we want, under Medicare and original Medicare, it said, everybody gets, you can't divide up the populations even on need. And I think Anne pointed out rightly that while we do think there should be guaranteed benefits for everyone, and adding some of these benefits in original Medicare would be beneficial, not inexpensive, but beneficial. But it is this targeting this really high need population that you've talked about, is a game changer for Medicare to enable that targeting. Is something you talked about. I don't know if you want to add anything.
I'm glad you connected the dots between that and the data, because I think this is where I think we've had these ideas before and in the healthcare reform back in the 80s and 90s, but we didn't have the technology and the data infrastructures and the AI and just all the things that we can do now to actually really find and people who and address their needs in a very individual manner that's going to make the difference. It's like precision. I think that word is perfect. So
it's interesting because they talk about precision medicine. You think about that as being some really high intervention. It's like a clinical intervention. And I think what we're seeing in Medicare Advantage is the use of data to identify who are frequent ER users, who actually was diagnosed with a serious condition but didn't come back to see any clinician. They can know who didn't fill a prescription. That was really sort of unknown to providers So now all of that can be known. So I think we have a couple of questions. Do we have any questions in the, yeah, great. Stand up so they can hear you.
Thank you. I was looking at the slide that said enhanced PCP, I'm assuming that means primary care provider. What does Medicare Advantage do to support the primary care providers who I'm assuming will now take on even more responsibility when we're after inflation?
And you want to try
Sure.
it? Yeah.
Yeah. So one of the challenges in Medicare fee-for-service is that the reimbursement for primary care is fairly limited. And when we use the term enhanced, it's kind of it's like a code word, but it really just means aligning the reimbursement for primary care to incentivize physicians to do things like provide after-hours care, be available, and not just physicians, but nurse practitioners. So, for example, I work with a senior housing provider who has a relationship with a nurse practitioner under a Medicare Advantage plan. That person is available after hours for triage to help the facility prevent the ER visit, and that and essentially to kind of for those of you who are familiar with it, there's a lot of wonderful models of this now. Oak Street Health, Iora Health, ChenMed, where they're essentially trying to kind of finance a much more robust, more time with the patient, more connection to community-based services, not just kind of like you have a 15-minute visit and that's all we can afford. More engagement with care management and things like that. So I think in the context of Medicare Advantage, that's those premium dollars are available to pay for all of those activities in the context of a primary care clinic, a primary care intervention, a nurse practitioner. And if you do it well and you have the right data and you target people appropriately, then you can begin to see reductions in hospitalizations and ER use.
Yeah, go ahead. There are two right there. So in the back. Go ahead.
Thank you very much, everyone. So now that we all know how wonderful Medicare Advantage is, why would somebody choose fee-for-service over Medicare Advantage? And what should people in this room go back and request or let their bosses know?
You want me to take it? Okay.
I think it's you.
Well, I think I think the biggest challenge in any kind of a private insurance system is the network of providers. I think that, and I will let Congresswoman respond to this as well. I think people get very attached to certain providers, and if they feel if they feel like they can't get access to those providers in a Medicare Advantage context, then they tend to avoid it. I will say also that I don't think we do a very good job as a federal government of explaining any of this to anybody. So I run a website for caregivers called daughterhood.org, and somebody called me up or emailed us, and they were like, their 90-year-old dad doesn't have Medicare. I was like, what do you mean he doesn't have Medicare? And they're like, he has this thing called Blue Advantage. So they don't. So I think there's a lot of work that we really need to do as a policy community around education so that people can understand it. And then finally, there's a lot of places where there just aren't very many options because of the way that federal policy and reimbursement mechanism works in rural areas in particular. So those are just a few. I don't know if you would add.
Yeah, I'll just add, and first of all, I would say we obviously advocate on Medicare Advantage. We think it is I'll go so far as to think it is the future of Medicare. It really is such an important part of Medicare. But we also recognize that it is a choice. And we have something called the Active Choosers Campaign, where we actually, again, are pushing the administration to make it more understandable. And I think some of the material, they've done a much better job in really explaining the key differences and what are some of the advantages or disadvantages of each. I think some of it is still in some areas people just don't do anything, so they default into Medicare, original Medicare. So we don't even know how many people are actively choosing Medicare. We did our own polling at BMA and found that over 60% of people in original Medicare didn't even know about Medicare Advantage. So they didn't even make that choice. And look, health literacy is really hard. Just how long it took us to explain this all to you, and you know something about this. And then you think it's really about my health care, and you think, I don't know what choice to make, and you postpone that choice, and then you default into original. Obviously, people who can afford a Medigap policy or are not as worried about a 20% copay, they might say, what difference if it's another couple $100? That's not most seniors. It's not most older adults. So we actually have been pushing the administration, but I will do a little tease here. We are working with some members of Congress to introduce a bill that would actually codify the importance and the need for CMS and Social Security Administration. I'm actually older than 65. I know that doesn't surprise anyone in this room necessarily, but you get this letter and it says, you're eligible for Medicare, and you're so thrilled about it. Then you find out you have to pay Part B, and you think, oh, I thought it was free. Okay, you have to pay Part B. And then you sort of feel like you're done, when in fact you're not. You might want Part D, we talked about this. You might want to know about Medicare Advantage. And where do you go? I will say area agencies on aging have 60% of the SHIP counselors. These are government-funded counselors who are supposed to be unbiased, but making sure they have the education about Medicare Advantage is
And
important.
funding.
Yes, that's right. No, and funding matters. And they help a lot of people. They're agents and brokers who also are there to be helpful. And then, of course, your friends and loved ones, who, but it's like choosing on the ACA marketplace. You all had to do that. You're like, okay, what are the choices to make? So I will say that more and more Americans, as they age, are used to making those kind of choices. Used to be your employer just told you what you got. Now you actually have choices. So you're a little more used to making choices, and so we think that's one of the reasons we're also seeing some more of an uptick. So, what people say, you have to accept the notion of a network and prior authorization and some of the tools that Medicare Advantage uses to keep costs lower. We have testimonials from many beneficiaries who said, I was nervous about making the choice, but I did, and I'm comfortable with it. But again, you get to remake that choice every year. So even if you sort of blew your, I don't like this plan, I want to choose another one, you can choose another one. If you want to go back to original Medicare, you can. And the only downside, which again you could fix, is that if you want a Medigap policy, if you have a pre-existing condition, those insurance companies can charge you more. And that does scare people into maybe not even trying Medicare Advantage. So by all means, don't let them do that, making sure that there's a guaranteed issue that's really state-run. Those insurance plans are really state-run, but still, federal government has some tools in this. So, but again, I think from your part, what we're asking policymakers to do is to support the option of Medicare Advantage and let individuals decide, and make sure that it is strong and viable enough, and that risk adjustment is accurate and fair, and that there's enough resources in Medicare Advantage to actually meet some of these expectations about meeting social determinants of community health. I think we have time for one more. And go ahead.
What is the rural to urban spread of Medicare Advantage, and is it available in more rural areas where it's harder to access Medicare care?
Great question. Beneficiaries, 99% of beneficiaries have access to an MA plan. So even in rural areas, there's access to at least one. They tend to be more in urban and suburban areas because of the density. But there's a lot of interest in, there is some MA in rural America as well. There is a good bit of discussion now about what changes in policy we might have to make to make it more available. One of the issues is, I'll say one negative and one positive. One of the challenges is that there are these network adequacy rules that are quite strict. So you have to have at least 2 specialists of every kind within, I think it's 50 miles. Well, in some rural areas, it's really hard to find 2 specialists in every, so psychiatrists are an example, that is not easy. But on the positive, this is where telemedicine is actually becoming really interesting, what if you allowed some of those visits to be done over by on Skype, and they're actually behavioral health, mental health. There's some real opportunities in that. You can even be in groups now, on Skype. So there's also even telemedicine between physicians and practitioners. Some very community hospitals have fantastic linkages with a tertiary care hospital, so you can maybe get at least a consult, without having that specialist in person. So we're looking actually at the possibility of maybe CMS changing some of those rules to make sure that it is more available within to rural older adults as well. So good questions, and thank you to the panelists. Thank you for your help and your being here, and for a successful event. Any questions, more questions, let us know. Yes, better Medicare Alliance. Exactly. In fact, you pick up a folder.
Lovely to meet you.
Okay, surely.
Yeah.
There should be some opportunity to just tell you where you get.
You have a card? You know, we do a lot of work with Courtney.
Yeah, no, I know. I did not bring them today,
Okay. I'll tell you what.
which is a terrible lobbyist, I know.
Yeah.
But if you have one, I would love to take one. But I also, I know
Why don't you
that.
jot
Oh,
down
perfect.
here?
Yeah,
How about that?
thank you.